Good morning, everybody. Thank you for being here. Most of the presentation I'm going to comment are dedicated to directly or indirectly to portal hypertension, and would like to recall the fact that portal hypertension is a consequence, an important consequence of cirrhosis of the liver. And in turn, portal hypertension is a cause of further severe and sometimes deadly complications for patients with cirrhosis. Therefore, any effort has been made to reduce portal hypertension and to measure portal hypertension, because if we are measuring portal hypertension properly, we are able to identify those patients at risk of developing cirrhosis-related events. And we have been using for decades non-selective beta blockers to lower portal pressure and to lower the risk of bleeding from esophageal varices. And we thought that the effect we were obtaining were closely related to the cardiovascular effect of these drugs. And in fact, these drugs lower cardiac output, and through this way, they lower the amount of blood which is reaching the splanchnic circulation, therefore decreasing portal pressure. This study that comes from Vienna is showing you and us that non-selective beta blocker may act also through a different pathway. And in particular, patients with cirrhosis taking non-selective beta blocker improve their intestinal permeability, which is abnormally increased in patients with cirrhosis, possibly due to the effect of portal hypertension. Increased intestinal permeability is important because it favors the so-called bacterial translocation, so the systemic spread of intestinal bacteria and bacterial products, such as endotoxin, bacterial DNA. And this systemic spread is bringing along an immunological response with an increased production of pro-inflammatory cytokines. And this, in turn, has hemodynamic effects, has effect on the coagulation, and so on. And what was very interesting in this study is that along with improvement in intestinal permeability, there was a reduction in the circulating levels of pro-inflammatory cytokines, demonstrated that this mechanism is possibly into action. And even more important, that patients who underwent a reduction in pro-inflammatory cytokines, such as interleukin-6, at a lower incidence of portal hypertension-related bleeding. So beta blockers reduce the risk of bleeding, not only through their hemodynamic effect, but also by modulating the translocation of bacterial products. And another interesting finding of these studies that these effects on intestinal permeability and bacterial translocation were obtained irrespective of the cardiovascular effect. So, I mean, these drugs are acting through different ways, possibly intestinal motility or modulation of local immunity. As I told you, to have a reliable measure of portal hypertension is important, because this helps us in identify patients at risk of developing complications. And this study that comes from the University of Bologna, and Professor Festi is here with us, is dealing with this topic, because up to now we have a reliable mean to measure portal pressure through the calculation of hepatic venous pressure gradient. But this is a technique, this is an invasive technique that requires catheterization of hepatic veins. So for the last year, scientists have been looking for alternative means of assessing portal hypertension through non-invasive approaches. Among these, the evaluation of liver elastography through fibroscan has given promising results. But these investigators put into mirror the spleen. The spleen is here, you see. Here we have the portal system. Here the cirrhotic liver. The cirrhotic liver makes a sort of barrage to the blood flow, so the pressure is increasing in this district, and the spleen is undergo a congestion. As a matter of fact, splenomegaly is a common feature of patients with cirrhosis. And the aim of this study was to compare the performance of the evaluation of liver and spleen stiffness compared to the gold standard, the measurement of the hepatic venous pressure gradient, in predicted clinical complication in compensated cirrhosis. Excuse me. As a matter of fact, the results were that in the univariate analysis, the gold standard liver stiffness, spleen stiffness, and MELD were predictor of clinical events. But in the multivariate analysis, the independent predictive factors were actually spleen stiffness and MELD. And their combination allow us to use a very powerful predictive tool. Now we move to a different field, but always related to portal hypertension. That means hepatic encephalopathy. And this study comes from a NISL Chronic Liver Failure Consortium, which was founded 3 years ago. And now we are starting to see the result of this collaboration between many European centers. And I was alluding that we are dealing with portal hypertension and hepatic encephalopathy, which is a neuropsychiatric syndrome, which is due to the simultaneous failure of the liver in clearing gut-derived toxins, and from the fact that because of portosystemic shunt, gut-derived toxins can access the systemic circulation and ultimately the brain. Among these toxins, ammonia play an important role. And sometimes some patients developed a chronic, invalidating, and difficult to treat encephalopathy. And there were some suggestions from Oliviero Riggio from Rome some years ago that in these cases there were large portosystemic shunts. And so large portosystemic shunt, either spontaneous, like in this case, or iatrogenic, as in patients with transjugular intrahepatic portosystemic shunt, can induce a chronic and difficult to treat hepatic encephalopathy. The author of this study addressed the issue whether it could be possible to make these patients improve by closing the shunt through embolization, and whether this could be done safely. And the results were quite good. In the short term, within 10 days, 60% of these patients with chronic invalidating encephalopathy were free of the symptoms. And almost half were free of the symptoms in a longer period of observation, and almost 80% actually improved their encephalopathy. So this treatment is effective. Is it also safe? Possibly yes. No mortality, just taking into account we are dealing with patients with very advanced cirrhosis. 8 procedures related complications, and they were mild. And in the long term, we have not any problem in terms of worsening of hypertensive gastropathy, gastroesophageal varices, and so on. So the conclusion was that this method is feasible, effective, and safe. And they also were able to identify, however, that patients who are going to benefit more from this technique are those with a sufficient functional reserve identified with a MELD score equal or below 11. I alluded to the fact that tips can also induce a similar clinical picture, and sometimes tips, because is diverting the portal blood from the liver, can induce an acceleration in liver failure. And again, from Leuven, this group addressed the problem of tips inducing chronic encephalopathy or liver failure. I would like to recall you that TIPS is a stent which makes a communication between the portal vein, the right branch in general of the portal vein, with the right hepatic vein. And in this patient who had either TIPS-induced encephalopathy or TIPS-induced liver failure, the narrowing of the communication through a technique, I won't comment on that, was able to make symptoms improve. Encephalopathy improve in 71% of patients with chronic encephalopathy, and liver failure was somehow stopped in half of patients. So stent reduction with this technique, parallel technique, improved chronic encephalopathy, refractory to medical treatment, and improve liver function, especially when made very early, as soon as the symptoms of liver failure were evident after TIPS. And the final study, again, comes from the Chronic Liver Failures Consortium. And the first big study from the consortium who enrolled more than 1,300 patients aimed at defining, studying the development and the outcome of the so-called acute and chronic liver failure have just been published in Gastroenterology. And these data come from that study and are related to the definition of a new prognostic score. In fact, patients with acute and chronic liver failure are patients with cirrhosis who develop a sudden deterioration of their condition. We have prognostic score, we have Child-Pugh, we have MELD score and the score derived from the MELD, but we also know that they do not perform very well in acutely ill patients. Therefore, in this context, quite often are used different score systems, which are used in general in the setting of intensive care unit, such as the sequential organ failure assessment. SOFA is the acronym score. And well, the aim of this study was to identify a new score, which has been called the CLIF-C, that means CLIF Consortium, based on the SOFA, enrich of variables which are not included in this score system, such as age, such as presence of ascites, such as presence of hyponatremia. And as a matter of fact, either in the short term, 28-day mortality, 90-day mortality, in the medium and long term, 180-day mortality, 365-day mortality. The performance, the prognostic power of the CLIF-C index was superior to that of the standard MELD or the MELD sodium, especially in the long term. So in conclusion, I would summarize as follows. In addition to proving portal hypertension, beta blockers can also reduce bacterial translocation, which may widen indication for the use of these drugs in this testing setting. Spleen stiffness measurement predicts the occurrence of clinical complication, and this, as I explained to you, is very important in clinical practice. Large spontaneous portosystemic shunts can be safely and effectively embolized to treat chronic protracted hepatic encephalopathy. And stent reduction with the parallel technique, I've seen Professor Neves is here, and he can eventually answer to the detail of the technique. This technique improves chronic encephalopathy induced by TIPS and halt the progression of liver failure induced by TIPS. And finally, this CLIF-C consortium predicts mortality more accurately of the other prognostic system we have in patients with acute and chronic liver failure. Thank you.